So it's been quite a while since I've done this content, and it's been over a year. A lot of people have been asking why I stopped doing the content, why I'm no longer posting these videos. But lo and behold, we're back yet again with another episode. Grab a piece of paper. Let's talk about the bazooka. Let's go. Hello and welcome to the Bazooka. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at 10 OSCE stations in one clinical course. This is season 5, episode 1. We are restarting the cycle and we begin with internal medicine as obvious. You already know the drill of this. Pause the screen before I give you the answer, write it down somewhere, argue with a friend, scream it at your screen, whatever you want to do. Let's go. Remember that the images that are portrayed in this may be graphical and they are only intended for teaching purposes. Station 1. Describe what is shown in the image. What is your diagnosis? List 4 clinical features the patient is likely to present with. Mention 4 risk factors associated with this condition. List 2 other pertinent investigations besides the one shown in the image. List 1 drug you can use in this patient along with 1 side effect. You may pause the video. And here comes the answer. So as you can see over here, you can see that there's a difference. Here you can see these spaces. You can't see those spaces there. The differentiation, the corticosulci differentiation. You can't see that here. So there's a problem here. You can see there's a large hypodensity here. So there's a large hypodense lesion on the left side, because remember, what is right on your screen would be left in the patient. What is left on the screen would be right in the patient. So this is the right side of the patient. This is the left side of the patient. So the left side here has this hypodense lesion, which is affecting the MCA territory. As you can see, it's quite significant over there. There's effacement of the corticosulci, and you can see that this ventricle here, the lateral ventricle, has been compressed compared to this other ventricle. So generally, there is what we call ipsilateral lateral ventricle compression. So this person has a left-sided MCA ischemic stroke. So the clinical features you'd expect, remember that if you have the stroke affecting the left side, often the symptoms are going to be there on the opposite side of the body because of the cortical decussation. So generally, you have weakness or paralysis on the right side of the body. You have aphasia, because remember that the Broca's area in most individuals, especially those that are right-handed, is going to be found on the left side of the brain. And even in those that are left-handed, still 90% of them are going to be on the left side of the brain. It's only in about 10% where you find the Broca's area on the opposite side in the right hemisphere of the brain. They may sometimes have aphasia, they may have neglect where they are unaware or unable to respond to stimulus on one side of the body. They may have headaches because this is quite huge. They may have a loss of consciousness, anisocoria, and vomiting. So the risk factors could be modifiable. Things like high blood pressure, smoking, obesity, diabetes, dyslipidemias, high cholesterol, atrial fibrillation, or non-modifiable risk factors. Things like increase in age. The older you get, the greater the risk. Race, it's very common in Africans, African Americans, Hispanics, and even males. Then in terms of 2 other investigations, you want to do an ECG and an echo, because most likely there's a blood clot that has come about. So you want to see the source of this. Maybe it's a cardiac in origin. You want to do a lipid profile. You also want to do a carotid ultrasound or a carotid Doppler. The drugs that you would use, you can use antiplatelet drugs, which are very important, aspirin or clopidogrel. One of the side effects of aspirin is, of course, you develop GIT ulcers with prolonged use. There's also risk of hemorrhage. And you can also use the recombinant tissue plasminogen activator, depending on when this patient actually presented. But generally, we can use alteplase, and generally the side effects are allergic reactions, arrhythmias, and sometimes hemorrhagic transformation, especially with the very large infarctions like this one. Station 2. What everyone loves to avoid. A 67-year-old female obese patient presents with history of shortness of breath, anasaka, increased JVP, and low BPs. An ECG was done and is shown in the image above. Describe the ECG in a systematic way. What is your diagnosis? what other investigations would you order for this patient? You may pause the video right now. And here comes the answer. So remember from our ECG bootcamp, by the way, if you haven't watched that ECG bootcamp, I will leave it tagged at the end such that you can go check it out. But this is standard calibration. How do we know this? These towers at the beginning here. Our first assessment is of the rhythm. It's very difficult to assess because we don't have a rhythm strip. But if we look at the rhythm of this ECG, we can see that the length from this to here is shorter than this to this, is also different from this to this. So there is an irregularly irregular rhythm. So generally, if you have an irregularly irregular rhythm, on your rhythm strip, you want to count for 6 seconds, or you can count for 3 seconds. So in this case, we can't count for 6 seconds, so we'll count for 3 seconds. So that's about 15 big boxes. So if we count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. How many Keres complexes do we have? 1, 2, 3, 4, 5, 6, 7, 8 Keres complexes. You multiply that by 20. So that's roughly a heart rate of about 160 beats per minute. But there is no rhythm strip here. We don't see any P waves. They are absent P waves. Maybe it's because of these low voltage waves that we can see in the limb leads, but it's very difficult to appreciate the P waves. And your cardiac axis is normal. So your lead 1 is facing upwards, lead 2 is facing upwards, lead 3 is facing downwards, but lead AVF is facing upwards. So a normal cardiac axis. If there is some sort of axis deviation, it's most likely a physiological left axis deviation. In terms of our RS wave progression, we can see lead 3 facing downwards. That's already a poor RS wave progression. Even when we come to the precordial leads, you can see V1 and V2 is predominantly facing downwards. V3 and V4, the transition zone is supposed to be, the transition point here is actually found at V5 actually is where the transitions are, not really V4. V4, V5, that's where the transition point actually is. But we can see that generally this is a poor RS wave progression. We can see almost immediately that the waves are quite small in terms of the QRS complexes, the P waves, the T waves on these limb bleeds. So maybe it could be because of the obesity of the woman, or maybe because there is fluid surrounding the heart, who may knows. Then if we look at, again, the QRS complexes that are there in these chest leads, we can see that this one is big, small, big, small, big, small, 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 big, small, big, small. So it's like it's alternating in amplitude. There are varying amplitudes of the QRS complex. We don't see any evidence of bundle branch block here. We don't see any evidence of hypertrophy or any evidence of myocardial infarction. So most likely this patient has a congestive cardiac failure because there are features of shortness of breath, anasaka, low, increased AVP and low BPs, and they most likely have an atrial fibrillation with a pericardial effusion. So generally you want to get your nitrogen terminus pro beta natriuretic peptide to see if there's any strain on the heart. You also want to get an echo for this patient, get a lipid profile, get serum lactate levels, together with your ABGs, do an HbA1c, get a chest x-ray for this particular patient. Station 3, describe what is seen in the picture. What is the most likely diagnosis? List 2 other diagnostic features of this condition aside what is shown in the image. What is the etiology of this condition? List the principles of management of this condition. And here comes the answer. So as you can see, this person here has the skin lesions, especially in the sun-exposed areas. So they have the dermatosis. This is very characteristic of pellagra. So generally, remember, pellagra is characterized by the Ds. You have the dermatosis itself, you have the dementia, you have the diarrhea, and if it's not treated, you're going to die. So it's often a deficiency in vitamin B3, which is niacin. So in terms of the treatment, you want to supplement the niacin, you want to have some dietary modifications, you want to address the underlying cause, you want to have some symptomatic management, and of course, monitoring and follow-up. Here's another image of pellagra. So generally, in terms of the niacin supplementation, oral niacin or nicotinamide actually can be used. And remember that nicotinamide is preferred because there are lesser side effects like flushing. The dose will depend on the severity of the deficiency and other individual factors. And of course, the duration, you give it until the symptoms resolve or until you address the underlying cause that was causing the deficiency. Then in terms of the dietary modifications, you encourage them to take niacin-rich foods, things like meat, poultry, fish, legumes, nuts, seeds, and even fortified cereals. And of course, they should have a balanced diet overall which is rich in the vitamins and the minerals. Or address the underlying cause. If it's a malabsorptive disorder, if it's alcoholism or certain medications, all those things must be addressed. Because if they're not addressed, this will keep coming back. The symptomatic management in terms of the skincare, you treat the lesions with a gentle cleanser, a moisturizer, sun protection. If it's a GIT, you manage the diarrhea and other GIT symptoms. If it's the neurologic things, of course, these ones may require some specific interventions. They should have regular medical checkups in cases of monitoring the progress of the treatment or any complications. And periodically, you should measure the levels of certain vitamins, like the levels of niacin and even the liver function test of this particular patient. Station 4. You're on call and receive a patient who shows you pictures of what happened to his fingers, as shown on the images on the right. What phenomenon is displayed? List 3 phases of this condition along with the reason behind each phase. List 2 conditions associated with this. You may pause the video right now. And here comes the answer. So this is obviously Raynaud's phenomenon, and remember that it's going to be associated with 3 phases. There's what is known as a white phase, where the hand is pale. So this is because you have this vasoconstriction, there's reduction in blood flow, blood supply to that particular area. Then remember, with reduction to blood supply to that particular area, it means even oxygen supply is going to be reduced. So they're going to eventually turn blue. So that's the cyanotic phase. And eventually, once the vasodilatation actually takes place, in re-establishment of the blood supply is there, they're going to become red. That's the stage of rubor or the red phase. So those are the 3 phases: white, blue, and red. So the conditions could be connective tissue disorders like scleroderma, systemic sclerosis, SLE, mixed connective tissue diseases, Sjogren's syndrome, rheumatoid arthritis. You could also have diseases of the arteries like vasculitis, atherosclerosis, Berger's disease, carpal tunnel syndrome. You could have repeated actions of vibrations like using vibrating tools, like those that have jackhammers, those that are typing or playing pianos, those that are smoking, some medications like beta blockers, vinyl chloride, some medications that have ergotamine in them, some cold medicines, even sometimes injuries to the hand or the feet like wrist fractures, surgery, or even frostbite. Station 5. Mention any 3 vaccines approved for COVID, and 3 COVID vaccines approved for use in Zambia. List 3 common side effects of COVID vaccines. Mention 2 drugs used in the management of COVID patients. List 2 side effects of each of the drugs mentioned in question 3. Define long COVID. You may pause the video, scream the answer at your screen. And here comes the answer. So generally, you could have AstraZeneca, Johnson & Johnson, Sinopharm, and even the Pfizer vaccine. Most of these vaccines, just like any other vaccine, will have pain at the injection site. You may have myalgias, you may have the fevers, you may have diarrhea, you may have headache, and in some cases, blood clot forming. Then 2 drugs that can be used, Paxlovid, which is a combination of nirmatrelvir and ritonavir, molnupiravir, it's very difficult for me to pronounce this name actually, and remdesivir. So Paxlovid can cause this metallic taste, it can cause increase in the BPs, muscle aches, diarrhea, headache, and dyspepsia. Remdesivir can cause renal dysfunction, low BPs, and headaches. And this other drug that I can't pronounce can cause diarrhea, nausea, vomiting, dizziness, and headaches. And remember that long COVID is this complex syndrome where you're going to be having this constellation of symptoms that are lasting 3 months or more after the first COVID symptom. Station 6. Describe what is shown in the picture. What is the diagnosis? What are the variants of the condition? List 1 drug used in the treatment of the condition along with 1 side effect. You may pause the video at this particular moment. And here comes the answer. So these are scaly, as you can see, they are scaly erythematous patches that we can see on the extensor surface of the arm very close to the elbow. So most likely this is plaque psoriasis. The different types of psoriasis, you have plaque psoriasis, which is the most common, gutted psoriasis, which causes this intense itching, inverse psoriasis, which is found in the creases like the armpits and the genitals, pustular psoriasis, which sometimes looks like does this pustules inside them that look like they have pus. Erythrodermic psoriasis, which causes the skin to fall off in sheets. Psoriatic arthritis affecting the joints, nail psoriasis, and scalp psoriasis. The drugs that you could use topical corticosteroids like hydrocortisone cream, which can cause thinning of the skin and skin discoloration and folliculitis. You can use the vitamin D analogs that can cause skin irritation, skin discoloration, acne, or even allergic reactions. Coal tar can be used, which increases your light sensitivity, hair discolorations, and even skin irritation. Retinoids can also be used that cause sun sensitivity, dryness, and redness. Calcineurin inhibitors like tacrolimus can be used, which cause renal dysfunction, high BPs, and high sugars. You could use some immunosuppressive drugs like methotrexate and cyclosporin, which predispose you to infections, and some biological agents like tumor necrosis factor alpha inhibitors or tumor necrosis factor inhibitors like infliximab, interleukin 12 and 23 inhibitors, and even interleukin 23 inhibitors, which do cause infections, especially respiratory infections. Station 7. Describe the findings shown on the image displayed. What is your provisional diagnosis? List 4 causes of this condition. List 3 drugs used in the management of this condition, including dosages in adults. You may pause the video at this particular moment. And here comes the answer. So generally we can see that there's this whitish complete area here at the upper aspect of the right upper lobe. So there's a homogeneous opacity of the right upper lobe. So most likely this is consistent with a right-sided lobar pneumonia, which can be caused by strep pneumoniae, Klebsiella pneumoniae, Haemophilus influenza type B, Legionella pneumophilia. And generally, we can use drugs like benzopenicillin 1 to 2 mega units, IV QID, ceftriaxone 1 to 2 grams, OD IV, or ampicillin 500 milligrams IV 4 times a day, or erythromycin 500 milligrams orally 4 times a day for those that are allergic to penicillins. Station 8. A patient presents with sudden history of shortness of breath and hemoptysis. Question 1. Describe the findings shown on the image on the right. What is the most likely diagnosis? Mention 4 risk factors associated with this condition. What other diagnostic investigations would you order? List 2. What treatment would you start the patient on, and how would you monitor them? And here comes the answer. So as we can see here, we have this triangular shape. You can see that this is shaped like a triangle. This triangular shaped opacity that is there, it's a wedge shaped opacity. We call this as a Hampton's hump. Given the clinical scenario that has been displayed to us, most likely this person has developed a pulmonary embolism. And remember, with pulmonary embolism or any blood clot forming, you have varicose triad, which is endothelial damage, and you have or endothelial damage or dysfunction. You can have the hypercoagulability, or you can have stasis of blood, anything that is causing that. So DVTs, heart disease like atrial fibrillation, malignancies, obesity, sedentary lifestyle, fractures of the pelvis or the limb, which may even be due to the fracture itself or even the treatment, immobilizing this patient for quite some time. Smoking, even COVID-19 has been shown to do this, endothelial dysfunction, high levels of homocysteine, and even combined oral contraceptive pills and pregnancy. The diagnostic investigation is, of course, a CTPA, a CT of the pulmonary artery. Then, of course, the D-dimers can also be done, but CTPA, most diagnostic. You can also do ECG, echo, a Doppler ultrasound of the lower limbs. In terms of the treatment, you want to give them your low molecular weight heparins like Clexane. You have to check your APT, and you have to check your factor 10, activated factor 10 assays. Then warfarin, you're going to be checking your INR. Remember, if you're using your warfarin in the long run, you need a heparin bridge. Then, of course, you can consider using your DOACs, your direct oral anticoagulants, the newer drugs like dapigatran, and usually these ones, there's no need for routine monitoring with INR like with the warfarin, but you need to check your creatinine clearance, your anti-factor 10 activated assays, your chromogen assays, and even your dilute thrombin times. Station 9. A patient presents with a history of abdominal distension, fullness, tenderness, and a palpable mass as highlighted along the dotted line on the image. What do you most likely think the mass is? How would you prove your answer in question 1 to your consultant? List 6 conditions that can cause this. What investigation will confirm your diagnosis? You may pause the video, write the answer, scream it at the screen, or scream it to your friend if your friend is very far away from you. If they're very close to you, that would be inconsiderate rather. Okay, so here's the answer. So generally, if it's a mass that's growing along this dotted line, it's most likely a spleen. So this person has massive splenomegaly or a massive spleen. So remember that it's going to be located in the left upper quadrant, and it's going to be extending obliquely towards the right iliac fossa. It will have a notch, and of course you can't go above it, you can't go below it. It's dull to percussion, and it moves with respiration. That's how you know that it's a spleen. It can be enlarged massively in chronic myeloid leukemia, polycythemia vera, indolent lymphomas, hairy cell leukemias, beta thalassemia major, visceral leishmaniasis, malaria, Gaucher's disease, which is an infiltrative disease, and Niemann-Pick disease, which is also another infiltrative disease. You can confirm this by doing a CT abdomen and an abdominal ultrasound. Station 10, which is the last station, another ECG. Describe the findings shown on the image. What is the diagnosis? I've already given you the diagnosis. It's a normal ECG. But really, I wanted to emphasize that sometimes on the exam, they do bring you normal ECGs, and we often see a lot of strange things from candidates, even when you bring them a normal ECG. So generally, this is a standard calibration ECG. The rhythm is regular, though there is no rhythm strip, but it's regular. And we can count about 16 boxes between these two RR intervals. So 1,500 divided by 16 is about 94 beats per minute. The cardiac axis is normal. The P waves are normal. PR interval is normal. QRS complex is normal. ST segment is normal. T waves are normal. So this is a normal ECG. So sometimes they do bring you normal ECGs on the exam. Last but not least, I want you to comment below. Describe the findings on the image. What is your diagnosis? I will leave a pinned comment of the person that gets it correct first in the comment section below. I really hope you enjoyed this episode of the Bazooka, and we look forward to having you back on the channel with more content as we cover more OSCE stations. Stay tuned. If you haven't yet subscribed, hit the subscribe button, hit the bell notification icon so you can never be missing on such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.